Welcome to the Nursing World Shared Practice Forum. I'm Dr. Elaine Meyer. I'm a nurse and clinical psychologist at Boston Children's Hospital. I am the director of the Institute for Professionalism and Ethical Practice, and I'm also an associate professor of psychology at Harvard Medical School. It's my privilege today to be here with Dr. Pamela Grace. Dr. Grace is an associate professor of adult health and ethics. She originally trained in the UK. She completed her baccalaureate and her master's degree in nursing in the United States. In 1998, she completed a PhD in philosophy with a concentration in medical ethics. And she has been actively involved in teaching medical ethics and moral reasoning for the past 20 years. She's lectured extensively and published widely. So, Dr. Grace, what led you to your interest and your focus on philosophy and ethics?
Well, first of all, thank you very much for inviting me here, Elaine. And it's really a privilege to be able to talk about this. So the reasons I got into pursuing a PhD in philosophy and ethics was that during my course of work in intensive care units and critical care units, and then after that as an advanced nurse practitioner in adult health, I came across so many problems in practice that I didn't feel prepared to address. I found them very troubling. I often felt that I was all alone, that I had no one to ask what's going on here. And mostly there were problems of not getting the patient the sorts of things that I thought they needed. So there were all sorts of obstacles to me giving good care to patients. And there were no ethics resources around in those days, or if there were ethics resources, they were sort of the purview of the physicians. They could call an ethics consult, but the nurses were sort of left on their own to try and figure out how they should resolve these problems. So in practice, and especially in intensive care unit practice, there are many obstructions to getting the patient what you need. It might be that there aren't enough staff, or the families pressuring the patients to go along with treatment they don't want, or physicians arguing with each other, or the team not talking to each other, people not being on the same page, lack of resources, and so on and so forth. But I often felt that I was really a very poor nurse because I didn't know how to address these problems, and we didn't tend to talk to each other about them. We might complain about being overworked.
So Pam, it really was your personal experience with moral distress then, and that sense of isolation that really prompted you to go on for your doctorate.
Yes, as part of the PhD, actually, I read an article that criticized nurses for using the term advocacy as sort of a mantra, because the woman who wrote the article said that nurses shouldn't use that to further their profession. And I thought, well, that sounds very strange because that's not what I'm doing. So I decided that I would look at the idea of advocacy in a lot more depth. What does it mean? And I came to the conclusion that it really, for nurses, it means that every action you take on a daily basis is about trying to do the right thing for patients. And so if you can't do those, like if you have your clinical judgment, your knowledge, your experience, and you know what the right thing to do is, and you can't do it, it's very troubling. And especially if you don't know how to articulate that in a way that gets everybody else on the same page. So that led me also to look at the issue of moral distress that nurses face. Many nurses are reporting that, their distress.
I'm wondering if you could tell us and our audience a little bit about what are the ingredients and what comes together to make a situation of moral distress for nurses?
So just to give some background on what's been done on moral distress more recently. So it started off that Andrew Jameton, actually, who was a philosopher who taught nursing ethics to nursing students, realized that a lot of the things they brought up in class were really about how troubled they were by what they saw in practice and what they felt they ought to be doing but weren't able to do. So he coined the phrase moral distress in 1984 in his book on nursing ethics. And his definition of moral distress was the negative responses that occur when you know the ethically appropriate course of action but can't carry it out. Since then, he's realized that many different healthcare professions, and in fact people in everyday life, experience moral distress when they're obstructed in doing what they feel is morally warranted, what kinds of actions are good.
Pamela, may I ask you, are nurses particularly vulnerable to moral distress compared, say, to other practitioners?
I would say that the research shows that people who are actually at the bedside and most in tune with patients do suffer a higher level of moral distress, probably because they face these situations over and over again. They know the patients, they have a connection with the patients. Often they're the ones that are actually pushing more medicines or doing more needle sticks or doing more interventions that are painful or uncomfortable. I would say probably the biggest hurdle for ICU nurses is this idea of having to do interventions that cause the patient suffering when it becomes obvious that the patient is not in a particularly good place, where they would perhaps be better off having comfort measures. But nurses often aren't heard when they try to articulate that in a multidisciplinary forum, or the physicians perhaps are more focused on trying to address the immediate situation, try and get the numbers better, try and get the physiological signs better. So I'd say in intensive care units, that's perhaps one of the reasons that nurses experience moral distress more. And in fact, I could give you some other examples. The research on moral distress in adult settings really surrounds end-of-life decisions, working with incompetent other providers, inability to have good communication, or there are mixed messages. The family members are getting one message from the physician, another message from the nurse, another message from the family, and they don't know who to trust or who to believe in. And then I would say witnessing on what they consider unnecessary suffering of patients. Also, when their environments of work are unsupportive, or sometimes people call them toxic environments. And one of the big issues has also been inadequate staffing, when nurses don't have enough bodies to do the work.
I wonder if I could turn now to our colleagues around the world and ask a question. First, could you state your city and your country location? And the question is this: are these the sorts of situations that cause moral distress for you in your settings and countries? Or are there other types of problems more frequent or concerning that cause moral distress?